So thank you very much, Christian, for the introductions. Thanks for the organizers for inviting me. It's a pleasure to be here. My topic is NAVA in patients with critical illness-associated polyneuromyopathy. I just wanted to point out that the results of this study have been published in intensive care medicine last year, and the main work has been performed by a fellow named Daniel Toucheo and a colleague from neurology, Werner Krocken. The work itself has been performed in the Department of Intensive Care Medicine in the University Hospital of Bern, Switzerland. Now, you have seen this slide before, the neuroventilatory coupling shown by Jennifer and other speakers as well, so I do not want to go in detail here anymore. I just want to point out, and you're aware of that of course each of the steps involved in the chain can be affected by some disease processes. Now, with NAVA, with a neurally controlled ventilator, all disease processes that affect the mechanical components further down the road are not as important anymore, but those affecting actually the factors or the components, the neural components involved up here, those might be important. And as you can see here, and you can imagine, the phrenic nerve can be affected by polyneuropathy, for example, or by other disease processes. And in addition, keep in mind that even the reflex system, which brings the information back to the brainstem, can be affected by the same disease processes as well. So that's why we're interested in studying patients which might have an impairment of this feedback system and of the phrenic nerves. Now, it was not known at the time to what extent the function of the phrenic nerve and diaphragm unit is affected in spontaneously breathing patients with critical illness-associated polyneuromyopathy, and whether the diaphragmatic EMG in these patients can be used to control a ventilator. In this particular study, we aim to assess the degree of neuromuscular impairment in a group of these patients compared to healthy volunteers, and to examine whether titration and application of NAVA for up to 3 days are feasible in this group of patients. Now, this is the group of patients we studied. We used 15 patients, or we studied 15 patients with clinically suspected and electrophysiologically confirmed critical illness-associated polyneuropathy, myopathy. The length of stay in the unit was in median of 29 days with quite a wide range. The patients were ventilated for a median of 6 days prior to enrollment, and 25 with quite a wide range days in total. Before enrollment, pressure support levels were fairly high, namely 20 in median with a range of 12 to 28 centimeters of water with a PEEP of 10 in median. Tidal volumes were 7.5 mLs per kilogram predicted body weight, and the PF ratio was below 200 in half of the patients and above 200 in the other half of the patients. In addition, we started 14 healthy volunteers without neuromuscular disease. Now, that's the study protocol, and let me just talk you through it. It looks complicated, but it's fairly easy. While still on pressure support, the conventional mode of ventilation, we performed the electrophysiological studies. I'm coming back to that in a minute. And we performed another study at the end of the study, or after completion of the study, actually. Then we just performed a novel level titration procedure, and I'll come back to this point as well in a minute, on a daily basis, and we implemented what we identified as an adequate NAVA level for 24 hours. And so on, up to 72 hours in total, unless the patient was extubated or dismissed from the unit before, which happened to one patient in this study. In addition, we performed a so-called standardized test of neuroventilatory efficiency during the sedation stop, which is part of the routine in this unit on a daily basis. And I'll come back to this as well. Now, this is just an example of a phrenic nerve stimulation. It was a cervical electrical phrenic nerve stimulation, and the response was recorded from the modified gastric feeding tube. In the upper panel, you might see a healthy volunteer with a typical compound muscle action potential response, and the lower panel it's just shown the same response from a patient with critical illness polyneuropathy. Now what you can see first is that the latency, so the delay from the stimulus to the peak of the signal is longer in the diseased patient, but even more so, the amplitude of the signal is much higher in the healthy volunteers and mostly suppressed in the diseased patient. Now these are the results of the group on the left side panel, left half of the panel, the healthy volunteers, which had a compound muscle action potential latency between 4.5 to some 7 or so milliseconds. The patients as a group had much higher latency, but there was quite a substantial overlap between healthy subjects and patients, and this has been described before, just indicating that the phrenic nerve is affected to a variable degree in patients with critical illness polyneuropathy. Now, in terms of the CMAP amplitude shown here, most of the patients, or virtually all of them, had lower amplitudes, clearly lower amplitudes than the healthy volunteers. So these patients, the patients we studied, had clearly critical illness polyneuromyopathy. This is now an example of a so-called novel level titration procedure, and Chris talked about it before. I just want to show it because it's a real patient data now, what we have done. We basically increased the novel level as shown by this fine line here in a systematic way, which is 0.1 centimeter of water per microvolt every 20 seconds. That's just what we did in all patients so far and in animals as well. And what we get in terms of response, and you have seen that before, is a kind of a two-phase response with a first steep increase in airway pressure and tidal volume, followed by a less steep increase or even a plateau in both parameters. At the same time, the diaphragmatic EMG just goes down, allowing the patient actually to display such a response pattern. Now, based on the data Christoph has shown you before and our interpretation of the two-phase response, that actually the first response phase represents the working phase where the patient is not actually happy with the assist he gets, and the second phase would represent a phase where the patient is happy with the assist, led us to the conclusion that the NAVA level just shortly above the transition from the steep to the less steep increase would be an adequate level of unloading. So that's what we call the NAVA level titration procedure, and that's what we did in all patients on a daily basis. Now, the reviewers of the patient just asked us to present all data on the titrations, and if you're interested, you're welcome to go to the online supplement of the publication and have a look at the responses. Not all of them are as beautiful as the one I've shown you before, but you might find that you are pretty able to identify the transition by yourself. Now, this is the group data of the study again, the respiratory pattern of the patient in terms of tidal volume, which decreased quite a lot as compared to the previously used pressure support mode, and the same is true for the mean inspiratory airway pressure above PEEP, which decreased substantially in this patient and actually remained stable over the 72-hour study period. And the same is true for the respiratory rate, which was just a little bit higher than on pressure support, and for the diaphragmatic EMG, which increased quite substantially, but remained stable over a 72-hour study period. These are the individual data, and as you can see, there is, for a respiratory rate, for example, no indication of any failure or respiratory failure or progression to respiratory failure, so an increase in the respiratory rate. The patient just kept their respiratory rate stable. What is interesting, actually, is that most of the patients, except for one up here, regulated their tidal volume into a range of 4 to 8 or maybe 9 mLs per kilogram of predicted body weight. A very similar response we found for the blood gases. This is now the PCO2 levels, was one of our concerns in this specific group of patients as well, similar to the sedation issue Paolo just told you before. So PCO2 remains stable in a physiological range, and those with a high level decrease their levels of PCO2 over time. For oxygenation, so the PF ratio, this ratio increased over time, over the 72-hour period, Now, we are not sure if this is linked to the ventilatory mode used or just to a general improvement of the patients. Now, that's the average tidal volume of the patients over the 72-hour period. So each dot would represent one patient. And as I told you before, the range was well between 4 and 9 mLs per kilogram, except for this one patient. What we found interesting is that there was some correlation between tidal volume and the phrenic nerve latency and amplitude, just indicating that indeed in these patients the tidal volume control by the neural feedback is affected to some degree by the function of the nerval system. But whenever the patients with a more diseased process or more severe disease process, they would choose lower tidal volumes and not the opposite. Now, the standardized test for neuroventilatory efficiency, that's a test we performed on a daily basis during the routine withholding of the sedation after the titration. The test was performed with an inspiratory assist of 7 centimeters of water, so in pressure support mode if the patient was intubated, or with 3 centimeters of water if the patient was tracheotomized. Each test lasted for a maximum of 60 minutes or was terminated prematurely if the patient showed any indication of respiratory failure. Now, the neuroventilatory efficiency test, basically, it's just an index between tidal volume and the diaphragmatic EMG, and it basically tells you something about the efficiency in converting electrical neuromuscular activity into tidal ventilation. So the more tidal volume you are able to generate for a specific diaphragmatic EMG, the more efficient you are to breathe. We thought that monitoring the neuroventilatory efficiency index may provide information on how the patient's ability to translate neural drive into tidal volume would progresses over time. And that's what we found in terms of in our group. For tidal volume, for example, during the first testing of the neuroventilatory efficiency from start to end, so these are the values, tidal volumes did not change. It was 6.2 to 6.6 ml per kilogram of predicted body weight. And the same was true for the last test performed in these patients. And when we looked at the time group interaction for these values, there was no significant change from the first to the last test performed. And the same was true for respiratory rate and the mean inspiratory airway pressure above PEEP. But for the index shown up here, so tidal volume over diaphragmatic EMG, there was indeed a significant change, but the numbers were small, or the changes were small in a way that in the first test, the efficiency went down a little bit, and in the last test, the efficiency went up. But again, the numbers or the changes were small in our patient. Now, we could not use NAVA in 2 of our patients. In one patient, NAVA has to be terminated after 6.5 hours because of high respiratory drive. They could not be suppressed by increasing the NAVA level. It just resulted in excessively high airway pressure and progressive respiratory distress. In another patient, NAVA was terminated after 16 hours because of frequent diaphragm myoclonic that repeatedly triggered the ventilator's backup mode and was just very annoying. Now, in conclusion, the respiratory center's output is accurate and vaguely mediated reflexes are sufficient in most critically ill patients with established critical illness-associated polyneuropathy, such that implementation of NAVA for up to 3 days results in stable cardiopulmonary function while preserving respiratory drive. Whether the assessment of neuroventilatory efficiency helps inform the weaning process requires further evaluation. Thank you very much.